Welcome to Cardiovascular Emergencies. This module is going to be a longer module because, well, you can figure out there's a lot of things to talk about with cardiovascular, but also this is the area with the most number of questions. There's 18 questions. That makes up 12% of the exam. Now, if you notice, if you're watching this on camera, you'll notice I'm not alone. Bill has joined me. Some of you may have already seen Bill in one of the other modules, but just in case, do you want to quickly introduce yourself, Bill?
Sure. I'm Bill Light. I am the Chief Operating Officer here at Solheim Enterprises. I'm also one of our speakers. So I'm an emergency nurse, as I think you probably are too. That's enough about me.
Well, let's dive right in and let's start with some cardiovascular physiology. A little bit of what I'm going to talk about may feel a little more like the CCRN exam rather than the CEN, but I think we have to remember a couple things. Number one, emergency nurses are considered critical care nurses, so we do have to have an understanding of some things that we may normally put over in that CCRN field. I would also just remind you that we care for patients now that are being held that are ICU patients. So we do have to have some understandings, and you may very well see some of the information I'm about to teach on the CEN exam. So that's why we're going to do it. And without further ado, let's do it. So let me ask a question. What assessment findings can you do just at the bedside to assess a patient's preload? What things are you using to assess preload? Can I ask you for a few, Bill?
Well, you can check things like where's the fluid going if it's failing.
Okay.
So the left side of the heart will push fluid back into the lungs.
Okay.
You can check like JVD. You
Yeah.
can check systemic volume. You could check, fluid in the system. You could check urine. You could check edema.
Yeah. So let me flip them up on the screen for you here. So some of the things that we can use to assess preload include lung sounds, urinary output, skin turgor or capillary refill, the presence of peripheral edema. And then on a hemodynamic side, we can use CVP because CVP measures the pressure in the vena cava. And we said the vena cava was like the faucet, it's the preload. So just so you know, CVP is normally 2 to 6 in a healthy patient. We actually consider CVP of 8 to 12 kind of normal in a critically ill patient because they tend to have some vasoconstriction, but that's kind of your normals. But let me push you one step further, Bill. So I'm going to ask you, each of those I just gave you, are they more indicative of left or right-sided preload? Because remember, you got preload going into the right side, but you also have preload going into the left. So starting with lung sounds, would that be more of a left or right preload?
Well, and you kind of said it. It's the filling pressure going into that side. So if you're talking about the left or the right, so your lungs come before the left side. So I would say lung sounds would be an indication of left-sided.
Absolutely. What about urinary output?
That's going to be systemic, so it would be before all of the heart. So I would say it's more right-sided.
Yep, absolutely right-sided. How about capillary refill?
Again, I would say that was systemic, so I would say right-sided.
And you're saying the right thing. What about peripheral edema?
Again, it would be systemic, so I would say it's right-sided.
Yeah, absolutely. And CVP overall is, of course, right because it's the vena cava, which feeds into the right side. So, yeah, overall, lung sounds are the main things we have to assess left side. Most of the systemic stuff, as you've already pointed out, is going to be right-sided preload. Now, what assessments might you use to measure afterload?
Well, so you're going to look at the resistive force going where it's going into. So you could do the same things, like you could look at perfusion, right? So if you want to do just bedside, right? You could do skin color or refill, and then we give you a general sense. But you can do the arterial pressure, right?
Absolutely.
You could do MAP or right. You can do an art line, I guss, if you want to, but that seems kind of extreme.
Yeah, for the most part, afterload is mainly measured by mean arterial pressure. your blood pressure is a measurement of what your heart has to push against, right? Now, the only thing I can't say is that you can't say your afterload's 120 on 80 because that's not a pressure. So I do have to get your mean arterial pressure to figure that out. But your mean arterial pressure is what you're pushing against. So that's really the major measurement of afterload. But, from a more crude standpoint, skin color, you're right. You said it. Could be a measurement of afterload. If your patient's really mottled, they probably, don't have a great afterload and so on. And then if you want to use hemodynamics, your SVR, your systemic vascular resistance, which of course requires hemodynamic monitoring, is going to be the most accurate way to measure afterload, normal being between 800 and 1200. Now, contractility in a lot of ways is the one we don't measure. There is a way. How could you measure that one at the bedside if you had to, crudely?
You can, crudely, you could estimate it with like the strength of pulses and quality.
Yeah. Pulse strength is the main one. Yeah. If you got a really, really strong pulse, you probably have good contractility. And the opposite is true. Other factors can confound it, but that's a crude measurement. Of course, as I said earlier, the most accurate measurement would be to go to ultrasound and get an ejection fraction, normal being 50 to 70.
Which ED nurses hate. You're like, oh my God, they're going to lock down the room for 45 minutes and lights down. And,
yeah. So that's kind of how we measure the different components of stroke volume in those different ways.
Okay.